Welcome to QD Clinic. I'm Jack Cush, executive editor of RheumNow.com. This QD Clinic is brought to you by RheumNow Live. It's going to be a great meeting. It's going to be shorter lectures, more discussion. In fact, I think about 47% of the total time is devoted to discussion, Q&A, polling, where you have a voice at this meeting. Yeah, it's a meeting of big shots and big topics. Be there. Today's case is enough is enough. Or maybe it should be when is enough enough. I presented this case last week at a medical meeting, and I began with just a listing of the past medical history of this 71-year-old white female who has rheumatoid arthritis. The past medical history has 68 diagnoses and entries and past problems. Most of them are currently inactive, past problems like a neuroma, a colon resection, low back pain, a MAC infection, a shingles infection, 2 dog bites, polyneuropathy, hemoptysis, 2 shoulder surgeries. You get the picture. It's complicated. And, she's done this over the last 71 years, acquired all this history, and she has rheumatoid arthritis, and you're going to take care of it. Who is she? She's a seropositive, CCP positive, rheumatoid factor positive RA patient who has also on the table bronchiectasis, fibromyalgia, MRSA, past history of atypical mycobacterial infection. You never get rid of that. Recurrent pneumonias, DVTs, vertebral fractures from osteoporosis, and 2 past shoulder surgeries for rotator cuff. She's currently taking 5 milligrams of prednisone, Xeljanz once a day, Plaquenil, Mobic, Cymbalta, Zanaflex, and gabapentin. Again, her diagnosis is RA, established by having chronic polyarthritis with synovitis of multiple joints. She's had nodules, she's seropositive, and she's had elevated CRPs in the past. Previously, she was treated with gold. Yes, she goes that far back. Prednisone, methotrexate, hydroxychloroquine, sulfasalazine, etanercept, leflunomide, Remicade, azathioprine, and rituximab. She's currently, as we said, taking what? Xeljanz and hydroxychloroquine and a nonsteroidal and prednisone. She's not yet been treated with anakinra, abatacept, any of the 2 IL-6 inhibitors, cyclosporin, or a cytotoxic like Cytoxan, nor MMF. I'm giving you options because now I'm going to tell you the patient has pain. She has back pain, she has knee pain, she has pain in her hands. She says she's not doing well on this current regimen, has not been doing well for the last 6 months. We didn't make much changes at the last visit. Are we going to make any changes today? She has multiple deformities, swan neck, boutonnieres, ulnar drift, some contractures. She does have some bogginess around the knee and maybe an MCP2. She has 11 tender joints today. Swollen joints are maybe 2. Hard to tell if it's really swollen when it's this deformed, this chronic, and this kind of boggy. Her CDI score and gas score is 24. Most of that is pain rather than TJC. And she does have tender points, meaning her fibromyalgia is never well controlled, and she doesn't sleep well and doesn't want to do anything for her sleep. So what will you do? She's been on a plethora of disease-modifying drugs. Do you try another one? Do you switch to another MOA? Do you go up to high dose tofacitinib, dose you're not allowed to use, 10 BID? That's a dose gives you more VTEs and maybe more of those ugly things we talked about in the last few months. Do you switch nonsteroidals? Do you up her prednisone? Do you add in a third DMARD? Again, there's not much she hasn't already tried. What hasn't she tried? Again, anakinra, abatacept, Actemra or Kevzara, cyclophosphamide, cyclosporin. When I presented this case to a bunch of colleagues, they were all over the map, as you probably are too. Meaning, do I try yet one more MOA? Do I go to IL-6? She hasn't received IL-6. She hasn't received abatacept. Maybe it's worth a try. Or do I just give up? Again, patients who have long-standing chronic disease with deformities, it gets to a point where it's hard to tell if, in fact, they do have synovitis. So your options are maybe go with a better imaging tool. The problem is not all synovitis detected by MR or by ultrasound is meaningful. In fact, it's got a sensitivity that's actually too high. And that's been really well proven. So, but if there's an abundance of synovitis, maybe you should treat it. I tend to think that while I'm doubting the accuracy and validity of my swollen joint cam, and believe me, I'm good at this, I think the thing I hang my hat on most is inflammatory markers. If CRP and sed rate are up, or there's other laboratory evidence of inflammation, hypoalbuminemia, anemia, chronic disease, thrombocytosis, I'm probably likely going to switch my DMARD, my biologic, my targeted synthetic to another biologic, another MOA. If not, I'm saying enough is enough, and my job is to ask her what her goals are as far as treatment. She really, at this visit, wanted me to pay more attention to her back pain and its management. And so that involved physical therapy, pool therapy, things she actually probably will do. And then maybe working on pain management without resorting to narcotics. But again, many rheumatologists would say you have to go through the full lineup of other MOAs to know that you really can't do anymore, meaning she needs an IL-6 inhibitor trial. She needs a trial of an IL-1 inhibitor. Maybe she needs a trial of abatacept as well. And you do each of those for what? 8 to 12 weeks before you decide go, no go? Again, these are hard decisions to make. I'm actually at the point of saying enough is enough. There is a point when you don't have to use the next DMARD when she's already received 9 DMARDs. Again, there's a diminishing return on DMARD efficacy as you go down the list. And what also goes up as you go down the list and you've been on multiple DMARDs is the risk of toxicity and the risk of infection. So again, very tough case. There is no right answer. If you see me, tell me what you think. Come to Room Now Live and tell me what you think.